Okay, so today we're having the pathology course. So after class at 6 p.m., we'll be going over to building 10. So if any of you want to learn some pathology, hang around. And our first speaker today is John Schiller. He graduated from the University of Wisconsin in Madison, and then he got a PhD from the Department of Microbiology at the University of Washington. He joined the Laboratory of Cellular Oncology as a National Research Service Award postdoctoral fellow in 1983, and he became a senior staff fellow. In 1986, he became a senior investigator in 1992, and now he's chief of the neoplastic disease section. His title, Vaccines to Prevent Oncogenic HPV Infections. John.
Well, hello, and thanks for some of you showing up in person. I know one person in the front row here, but other than that, I don't know the rest of you. Well, oops, it probably wouldn't hurt if I turned on the mic so people. So hi out there in video land as well. Is this working? Can you hear me okay? Okay. So what I'm going to talk to you today about is concentrating on vaccines to prevent oncogenic HPV infection. So I'm not going to be talking about any therapy, but rather talking to you about prevention measures. I'm going to start by telling you a little bit about the connection between HPV and cancer, tell you a little bit about burden of disease, a little bit about mechanism, but I'm not going to get into it too much. And then I'll be spending a good portion of the talk talking about the current and future prophylactic HPV vaccines, tell you a little bit how they work, how well they work, and maybe why they work so well. And then get in, if I have some time in the end, get into some of the implementation issues where we start to deal with the problem that we have something that we think is a very good intervention to prevent cancer, but the problem is getting people to use it and getting it to the people who need it the most. So I think you're not getting any other lectures on the association between cancer and infectious agents. So let me just put up this slide to show you the infectious agents that are associated with cancer. To point out that it's been estimated that somewhere between 16 to 20% of human cancers are attributed to infectious agents. And what we're going to be talking today about is human papillomaviruses, which is responsible for about 30% of all cancers that are associated with infectious diseases, mostly cervical, anal, penile, and oral pharyngeal. Now, like HPV is like other infectious disease-associated cancers where the burden of disease is disproportionately in the developing world. Here's the arrow for cervical cancer, but it's also true for these other diseases as well. So again, when we're thinking about interventions, we have to not be satisfied with getting interventions just to the United States in highly developed countries, but getting them down to the people who really need them. So when we look at the worldwide burden of HPV-associated cancers, we definitely focus on cervical cancers. It should be obvious here why, because it's both the largest number of total cases annually and also the largest attributable fraction, basically 100%. There's almost no cervical cancers that don't have HPV in it if you look carefully. Now, if you look at the types, there's about 200 different HPV types that infect people, but a relatively small number, about 12, are considered oncogenic. And of these worldwide, two types, 16 and 18, account for about 70% of cancers worldwide, and in all regions of the world. After that, there's a little bit of mix as to what comes 3, 4, 5, and 6, but it tends to be one of a group of about 5 types. Now, if you look in the developing world, the burden is a little bit different than it is worldwide, and especially low resource settings, for 2 reasons. First of all, we have really good PAP screening program. And this PAP screening program has reduced the incidence of cervical cancer by about 80%. Without that, we'd have sky-high rates of cervical cancer. And the other thing is that we've had what's been considered an epidemic of HPV-associated oral pharyngeal cancers. And so because of this, it's been estimated that in the next coming years, that the non-cervical HPV-associated cancers will actually be more cases than cervical. And as you can see shown in gray, an appreciable proportion of these cancers are in men, especially oral pharyngeal cancer. For reasons that are not entirely well understood, about 65% of oral pharyngeal cancers are in men. The types that cause cancer tend to be clumped in this one phylogenetic group here, where 16 and 18 here is on two different branches of it. Another setup cause genital warts. 6 and 11 cause about 90% of genital warts. Other groups cause hand warts, foot warts. There's a large group that are just basic asymptomatic that infect all of us but don't do anything. And we actually don't worry about them too much unless you're immunosuppressed. Now, HPVs have a really peculiar life cycle in that the entire cycle takes place only in the stratified squamous epithelia. So we believe that this lifestyle is mainly evolved to evade immune recognition. So in the lower levels of the epithelium, where the virus infection is being maintained, there's very low levels of what are called the early proteins, the non-structural proteins, non-variant proteins that are involved in autonomous replication of the DNA genome. It's got a double-stranded DNA genome, and transcriptional control to keep it tightly regulated. But then as these keratinocytes differentiate, the virus responds to certain differentiation-specific signals and kicks into high gear. And now starts making a lot of proteins, in particular the virion proteins, and over-replicates its DNA genome, and you get virions being assembled in the upper layers of the epithelium and shedding of the virions to the external surface, either your skin or into mucosal surfaces in the mouth and the vaginal tract. And so thereby it avoids immune evasion. And just to show you this briefly, what it looks histologically, in pink is MCM, which is a cellular protein that's induced at high levels by E7. It's very difficult to actually see E7, but it shows that E7 expression is in these lower levels here, whereas E4, which is a marker of making virus, you can see is just made in the upper layer. And the lesions, especially of high-risk types, are often very hard to detect. This little white region here is actually a HPV-16 infection. And so now we can kind of understand cervical carcinogenesis from the point of view of the virus. People knew for quite a while that cervical cancer was a sexually transmitted disease because prostitutes had relatively high rates of cervical cancer, whereas nuns had relatively low rates of cervical cancer. But we didn't know what agent was responsible. But now we understand cervical carcinogenesis from the point of view of the HPV. And so if you go and get a pap smear and you have a low-grade lesion, which is called low-grade squamous intraepithelial by cytology or histologically, cervical intraepithelial neoplasia grade 1, this is just a manifestation of an HPV infection. You're just looking at infection. And most of the time, these infections clear spontaneously, but if they persist, they can go on to higher grade dysplasias, moderate severe dysplasia, carcinoma in situ, in which the entire layer of the epithelium is proliferating. And this is associated with increased levels of E6 and E7 expression, often but not invariably, integration of the viral genome into the host DNA and progression onto cancer. But this is a relatively rare event. This is a very common event. Now, you might be thinking, well, why does the virus have oncogenes? It doesn't have oncogenes because it's good for its life cycle, because these cancers are so dedifferentiated that they don't have the right signals to induce production of the virus. Okay, so it's as much a dead end for the virus as it is the host. But the reason we think it has oncogenes is because it has a problem. It's trying to replicate its DNA in cells that are terminally differentiated. What does terminally differentiated mean? It means it doesn't replicate the DNA. So it's got to induce the machinery for replicating DNA, the cellular DNA, by its oncogenes. And so what it does is it has one protein, E7, that induces aberrant proliferation. But this is a problem because if you induce aberrant proliferation in a terminally differentiated cells, what does it do? It causes apoptosis. And so another protein, E6, blocks this apoptosis. And together they induce immortalization and also rapid genetic instability, which leads to transformation and eventual carcinogenesis. Now, both E6 and E7, E6 is about 150 kilodalton protein, and E7 is 100. But even though they're very small proteins, they interact with a whole lot of different elements. But the main thing E7 does is it inactivates RB, which is this master regulator of going into S phase. So if RB sits on E2F here, it prevents E2F from acting as a transcriptional activator to activate a lot of the controllers of cell cycle. And so it inactivates this and allows cell cycle to be induced. Now, E7, again, does many things, maybe even more. But again, the primary thing that we think that's responsible for carcinogenesis is that it inactivates P53. And the way it does this is it has a ubiquitin ligase. It attracts ubiquitin ligase to P53 that's not normally associated with it. It gets ubiquitinated and then degraded. It also, interestingly, activates TERT, which is the enzymatic component of telomerase. And so this is one of the main features in which it induces immortalization. Now, one of the interesting things about HPV-associated cancers is that generally it happens at a very particular place in the epithelium. And this is the place where stratified squamous epithelium meets columnar epithelium. And this is called the transformation zone. And this is the place in the cervix where cancers initiate. Now, anal cancer, which is also relatively common, also occurs at a transformation zone. So that fits that pattern. Now, infections of the penis, the vaginal tract, the vulvar, they're actually probably just as common as cervical infections, but they actually quite rarely go on to become cancers. And we think the reason they don't is because there's not a transformation zone in those situations. That's why we think that cervical cancer is very common, whereas HPV-associated cancers are less common in males because they lack a transformation zone. Now, this carcinogenic progression, this is actually a picture of the transformation zone from simpler columnar, which is more red, to this pinkish stratified squamous epithelia, and this dysplasia, high-grade dysplasia here, progressing to cancer takes quite a while, on average of more than 10 years. This allows a long time for detection of these lesions by Pap screening. Now, the timeline for cervical cancer progression is shown here. So HPV infections are very common in younger people. Lifetime incidence of genital HPV infections is considered to be over 80% in the US. So having a genital HPV infection is almost synonymous with being sexually active, very common. But most, as I said, most infections clear spontaneously, eliminating the risk of cancer. But if you have persistent infection, this is on the causal pathway for cancer. And usually precancers, high-grade dysplasias, take about a decade to be acquired, and then cervical cancers start coming up about a decade later and then basically plateau. But cervical cancer actually is a cancer that affects relatively young women. And so one of the devastating things about cervical cancer is that oftentimes when women are most responsible for their families is when they get cervical cancer in developing countries. So Pap smear screening, which I've talked about, is what we call secondary prevention, where you actually get an infection. If it either goes away, if it doesn't, you get this abnormality, and then you follow this relatively complicated procedure. And if you have precancerous disease or you have frank invasive cancer, you get treatment. What I'll be talking about today now is what we call primary prevention, where you stop this whole process at the very beginning by preventing the initial infection. I hope you can appreciate that stopping it here is a much easier thing to do than to go through all these things. And in cervical cancer screening by the Pap smear, although it works well in developed countries with organized screening, in most of the world it doesn't work well. It's too complicated and too expensive. So moving on to talk about the vaccine, we started working on this vaccine in the early 90s. And at this point, what we knew was that if you take real virus of an animal, let's say a cow or a rabbit, and you inject it intramuscularly where the virus doesn't replicate, you generate antibodies, and those antibodies prevent infection with that same virus type. But what happened with people is that we tried, for the HPVs, we tried to generate an immunogen by either using denatured forms of the major virus protein, which is called L1, for instance, made in bacteria in a denatured form, or shorter peptides, and they didn't generate any neutralizing antibodies. So therefore, we figured that the key to generating an immunogen would be have conformationally correct L1. But the problem is that there was no scalable source of authentic virus for making, like, for instance, an inactivated vaccine, like, for instance, hepatitis A. We just couldn't make enough because the only place the virus gets made is in terminally differentiated epithelial cells, and they don't make any virus in replicating cells. And so what we did is we thought, well, let's just try to make this L1 by itself in insect cells via a baculovirus expression vector. And we picked this system because, one, baculovirus expressed protein had been acceptable for clinical use at that time, and two, because it makes a whole lot of protein in this assembly reaction of 360 copies of this L1 may be driven by concentration. And lo and behold, when we did it, it spontaneously assembled into particles which, for all the world, look like the outer shell of the virus, okay? But it didn't contain any of the viral genes, because the only thing being expressed in this was the L1 from a baculovirus. It didn't contain the oncoproteins. But more importantly, it not only looked like the virus, but when we injected it into animals, it made sky-high titers of antibodies that prevented infection of tissue culture cells. Okay, this is called virus neutralization. And virus neutralizing antibodies is usually the key for most therapeutic vaccines. But since it didn't contain the virus genome, it was non-infectious and non-oncogenic, so it provided a plausible way of moving forward with the vaccine. And we talked to a bunch of different drug companies to try to develop this vaccine. And at this time, there was a lot of skepticism as to whether the vaccine could work, because they basically said STD vaccines have been tried for herpes, they've been tried for HIV, and none of them worked. And all you're going to do is, if you have an infected partner, you're going to get so much exposure that maybe at best you'll delay infection by 2 or 3 months. And in terms of getting cancer 20 years later, 2 or 3 months doesn't make any difference. And so it's very hard to convince drug companies to go forward with this. But eventually we were able to convince GlaxoSmithKline and Merck, which fortunately were two of the best vaccine manufacturers in the world, to invest a couple $100 million to try to develop this vaccine. And they did parallel independent development. And the Glaxo vaccine, which is called Cervarix, is bivalent. It contains 16 and 18, which again causes 70% of cervical warts. And they make it in insect cells by baculovirus the way we did originally. They use a proprietary adjuvant. It's called ASO4, and it contains aluminum salts, which is in most prophylactic vaccines, but also something called monophospholipid A, which activates TLR4. And this is the first TLR4 agonist adjuvant that's been FDA approved for a prophylactic vaccine, so it's kind of a milestone. So Merck initially developed a quadrivalent vaccine, again, 16 and 18 for cancer, but they decided to throw in 6 and 11, which account for 90% of genital warts. And it's a regular aluminum salts, alum adjuvant, and it's made in yeast. And the reason they probably made it in yeast is because they were already making a hepatitis B vaccine in yeast. It's important to note that in the trials and after licensure, the vaccine is delivered by intramuscular injection at 0, then either 1 or 2 months, and then 6 months, 3 doses, okay? Now, this slide depicts how long it took to develop this vaccine. And I think the lesson here is if you want to do translational research, you better be in it for a long haul if you really expect it to work out. Because the virus was discovered by Harald Zerhausen and his colleagues. And Zerhausen actually got the Nobel Prize a few years back for this discovery back in 1982. It took us 10 years to produce the VLPs for various reasons. Some of it we just weren't smart enough to do it earlier. But then from this point, even though there were 2 drug companies working as hard as possible in competition with each other to be first in market, it took 15 years before the vaccine was licensed in 2006. Now, importantly, during this time, there was a series of molecular pathogenesis studies and also epidemiological studies, first case control, and then prospective studies, that led to the conclusion that HPV was the first necessary cause of cancer. So this really provided the impetus for both developing the vaccine and then using it in the general public. And it was critical for developing this vaccine to understand the association between precancer and the development of carcinogenesis by the virus and cancer, because we could never have used cancer as the endpoint of the trial. And the only way we would have been able to sell this vaccine is if we had a label that said it prevented cancer. And the reason we couldn't have cancer as an endpoint in the trial is twofold. First of all, it would have taken a 20 or 30-year trial, and there's just no way you're going to run a 20 or 30-year trial, because remember, we're trying to prevent the initial infection, and it takes a really long time for that initial infection, on average, to develop cancer, at least 10 years. And the other thing is, because if there was active follow-up in this study, we would identify the pre-malignant lesions, and they would have to be surgically excised ethically. You can't let people go on and get cervical cancer while you're watching them, okay? And so the only way we could move forward is to have a biomarker for cervical cancer, in this case, intermediate and high-grade dysplasia, because everybody believed that if you prevented these lesions, you would prevent cancer. And it's got a little bit moved around, but so these vaccines have turned out to be remarkably effective. With these vaccines, everything we did from preclinical days all the way through the clinical trials to the latest data I'm going to show you a little bit later, they've always exceeded expectations. So, I mean, we've really been lucky with this. They've always been really good. And so this shows some of that data. So if you look at protection against the most cancer proximal outcome, cervical and intraepithelial grade 3, this is basically carcinoma in situ. And you look at efficacy of the VLP vaccines against incident disease by vaccine-targeted types in people who had no genital infection, in women who had no genital infection detected at entry. And this actually is the closest that we can get to young adolescent girls who are the main target of vaccination. You can see that the average age here was 15 to 25, so most of these women were already sexually active. But if they didn't have any HPV at entry, you can see the efficacy of both Cervarix and Gardasil against SIN3 caused by the vaccine-targeted types was 100%. Gardasil was also 96% effective at preventing genital warts, because remember, Gardasil attacks 6 and 11. If you look at, in males, if you look at anal intraepithelial neoplasia or genital warts, it looks like protection is a little worse in men, but we think the main reason for that is that it was more difficult to detect prevalent infection. We missed infections when we tested. It's easier to detect prevalent infection at the cervix than on the male genitalia. And so that what we had was that some people actually had infection, we missed it, they got vaccinated, and then these infections emerged. This happens in women a little bit, but not as much as in men. So clinical evidence of efficacy, I talked about cervical, but there is actually some evidence against all of these other cancers as well. If you look at infection, we have some evidence against all of them. If you look at dysplasias, in addition to cervix, we have evidence for anal dysplasias, vulvar-vaginal dysplasias. We don't for penile lesions because they're just so rare. It doesn't happen very often. And so the trials have to be very large to power it on that. And we don't have it for oral pharyngeal lesions because we actually haven't identified the pre-malignant lesions. So it's unlikely that this vaccine will ever be licensed for preventing oral pharyngeal cancer, but it's likely that it will prevent it because it prevents oral infections. So what the vaccine doesn't do is they don't prevent infection or disease caused by most of the other types that cause around 30% of cervical cancer that aren't caused by 16 and 18. There's a little bit of cross protection for some very closely related types. So we don't say they're type specific, we say they're type restricted. I'm not going to show you a lot of that data because it's all kind of confusing. And the other thing, unfortunately, they don't do is they don't induce regression of established HPV infections or prevent progression of HPV-induced lesions. So if you already have your infection and now you get vaccinated, it's not going to do anything. That's why it's so important that for vaccination programs, you get the vaccine before you're exposed to the virus, because that's the way you get the most benefit out of it. So as I said, 16 and 18 account for about 70% of cancers. Well, what about these other types? Well, Merck has been working on a vaccine, which they call their nonavalent vaccine, which was just approved less than a year ago. And in addition to 16 and 18 and also 6 and 11, it contains the next 5 types that are associated with cancer, from about 4.4% to 2.5%. And so if you look at the antibody, so for this trial, they couldn't use a placebo control because Gardasil and Cervarix were already licensed. You can't deny something that's of benefit to people in a study if it's FDA approved. And so this had to be what's called a non-inferiority study for immunogenicity against 6, 11, 16, and 18 relative to Gardasil. Okay, so the comparison was Gardasil 4 against Gardasil 9. And so all they could do for the types that were common to it is show that it's as good as. And so what they showed is the immunogenicity was the same, okay? And that was an absolute criteria by FDA. But then they looked at these other types here, which Gardasil doesn't protect very well, and they showed 96% efficacy against intermediate and high-grade dysplasias by the 5 additional types that aren't in Gardasil 4. So again, you can add a bunch more types and still get very good protection against the new types. So this now becomes the gold standard, and it has the potential of protecting against about 90% of the HPV types that cause cervical cancer. Now, how does this vaccine work? It works better with coffee. But so we think that this vaccine probably mostly induces sterilizing immunity in people. And this is something that when we started, this was the big kicker. No one believed that an STD vaccine could absolutely prevent infection, so that you never got infection despite multiple exposures. Because most vaccinees never test positive for HPV infection as measured by sensitive PCR assays. And when we do get breakthrough infections, they tend to appear early in the trials rather than farther on. So why would a vaccine protect better in year 3, 4, 5, 6, 7 than in year 1? Again, it's this idea of emergence of prevalent infection. So what we're doing in that first year is basically getting rid of the infections that were pre-existing when we vaccinated and then emerged during the vaccination period, okay? Because it's not therapeutic, so we're not protecting against those. And so most of those, quote, breakthrough infections happen in the first year. And after that time, protection has actually gotten better rather than worse. I'll show you why we think that is in a minute. And we think that antibodies are the primary and perhaps the only mediator of protection. And this isn't so surprising because other prophylactic vaccines against infectious disease, we think that are mainly functioning due to antibodies. So first of all, we generate high levels of neutralizing antibodies routinely, and I'll show you that in a minute. And when we do see cross-protection in the clinical trials, it actually mirrors the antibody-mediated cross-protection, cross-neutralization we see in vitro. Importantly, we can do passive transfer experiments where you vaccinate one animal, take the serum out of that animal, put it, just the serum or just the antibodies, put it in a naive animal, and then challenge the naive animal and get complete protection. So that shows that antibodies are sufficient because all you're transferring is antibodies, and we can get complete protection. And the other thing is this L1, this protein that's in the vaccine, isn't detectably expressed in the basal epithelia where we think the infection is being maintained. And so it's pretty hard to get rid of cells that aren't expressing your antigen. And that's why we think it doesn't act therapeutically. Now, it's important to note that the various types are individual serotypes. I told you that we don't get much cross-protection, but they vary in multiple loops on the surface. So we actually think that people are responding to multiple loops, not just one completely immunodominant epitope. And the reason this is important is that it's going to be hard for the virus to escape this pressure of antibody neutralization by the vaccine by just changing like one amino acid on its surface. If you have 3 or 4 or 5 places that the virus antibodies can bind and prevent infection, it's much harder to do that. So one of the questions is, how does the antibodies that we generate get to the cervix and induce protection? This is an example of a completely mucosal virus. The only thing that infects is the epithelium, and yet we're not invoking any measures of mucosal immunity. So we think that the systemically induced antibodies get to the cervix and protect by 2 mechanisms. One, the cervix is an unusual tissue, or the female reproductive tract, in that there's what's called transudation of serum IgG. So there's active transport of IgG from the serum into the cervical vaginal mucus. This also happens in the lower respiratory tract, but for instance, it doesn't happen hardly at all in the gut or in the oral cavity. So that's a break. But more importantly, we have good evidence that in order for this virus to infect, it's got to bind the basement membrane that separates the dermis from the epithelium. And then we've actually studied this. I won't go into it in any detail. Then these cervical the basal keratinocytes migrate in here and bind the virus, and only then can we get infection. But the fact that you need trauma or exposure of this region means that you're going to get a direct exudation of serum antibodies from the capillaries or interstitial antibodies. So the virus is trying to come down here and infect against a gradient of antibodies coming up here. And we think that's actually the main reason for protection, because Gardasil induces virtually 100% protection against genital warts, and a fair number of genital warts are actually on coronified skin that isn't bathed by mucus. So this exudation aspect is probably how that's protecting. So we think that that's sufficient. Now, the vaccine is remarkable in its ability to consistently induce antibody responses. And this is just a study, an early study from Gardasil, where you can see it's 100% to a rounding error. Even more remarkable, and this is data from Cervical, where it's going out to over 9 years, is that the antibody titers drop maybe about 50-fold in the first year and a half or 2 years. But after that, it's basically level. There's no significant drop in antibody titers after that. So we reach a plateau level. So we're generating long-lived, what we call long-lived plasma cells that are probably that are in the bone marrow, that are pumping out antibodies, that we think they may pump antibodies out for the rest of your life. So even after 9 years, 100% of vaccinees are still seropositive at levels that are at least a log higher than what we find after natural infection. So this is really encouraging that this is basically everybody gets to this state. Now, the reason we think that this vaccine is so exceptional in inducing high levels of antibody is because B cells recognize the dense repetitive protein array as dangerous microbial structures. So if you look at sort of monomeric or soluble proteins, the kind of proteins that normally float around in our bloodstream, even if they're foreign, you get binding but relatively weak activation signals and relatively low antibodies, and most of them go away. But when the virus when the immune system sees this virus-like structure, it leads to cross-linking of the immunoglobulins, which form the B cell receptor on the surface, cross-linking of the attached tyrosine kinases, and leads to very strong proliferation signals, high levels of antibodies with a durable response. So we really think this sort of virus-like structure is the key that the immune system hones in on to generate strong immune responses that are going to last forever. So duration of protection, we don't know how long the vaccine is going to protect. We're at about 10 years now, and as I mentioned, there's no sign of waning protection. And no increase in the number of breakthrough infections as we go on. But again, if the antibody levels are the same and antibodies are the mediators of protection, you'd expect that protection would continue to last, and that's what we've seen so far. Now let me just turn to some more recent data that's come out of a trial that the NCI has sponsored down in Costa Rica. I have to say, when these two companies decided to go and do these trials, these were two of the best drug companies in the world, as I mentioned. So then we got to thinking, is it worthwhile for the NCI to run a separate trial? And we debated back and forth because these are going to be expensive trials. But it turns out we're really glad we did, because we generated data that would never have been generated by the drug companies. I'll show you one example of this data, because we were interested in more than just getting the vaccine licensed. We wanted to understand the vaccine and investigate other parameters. And so what this is we decided, well, let's look at what happens in the women who get less than 1 dose. The drug companies would never look. If they get less than the 3 doses prescribed, they're just out of the trial. But we continued to follow them, and we looked at what happened. And what this shows you is that, and this isn't a post hoc analysis, so it's important to note that these women were not randomized to get 1 dose. They just happened to get 1 dose, okay? So it's not as strong a data as if you would do within a randomized trial. But it's very interesting nonetheless. So what happened is, if you gave a woman 1 dose, it turns out very unexpectedly, they also got a plateau level of antibodies. If you looked at the peak titers, there was more than 100-fold difference at peak. And when you boost a lot of antibody responses, but these are short-lived. And surprisingly, if you looked at the end of 4 years, there was less than a 4-fold difference from giving those 2 extra doses. So there's really very little bang for your buck from those extra doses. And at the end of 4 years, when we looked at protection, for 1 dose, it was only 100%. Okay. And the confidence intervals are actually not too bad, 79 to 100. So it looks like we're getting pretty good protection from a single dose, and it looks like the antibody titers are being maintained. And we have unpublished, so that the data I just showed you was published, but we just recently were looking at some unpublished data where now we're out to 7 years, and again, we have no breakthrough infections, and the antibody titers are continuing to be stable. And this just shows some of the infection data. So if you look in the new time points between year 4 and year 7, when you may be thinking antibody protection is waning, if you look at 3, some ladies only got 2 doses at 0 and 6 months, and some ladies got 2 doses at 0 and 1 month. As you can see, there was basically no infections coming up between year 4 and year 7, no matter what we use. There were some infections by these 3 types. We get some partial cross protection, but importantly, they're still getting a good number of infections by genital types that aren't protected. So why this is important is it means they're still getting exposed to genital HPVs. It's not like they've stopped having sex or having partners that are infected, okay? Because they're still getting infections by other genital HPV types. And there's not really any significant difference between those that got 1, 2, 3, or 4 doses, 1, 2, or 3 doses, okay? So it looks like we're getting continued protection. And right now, we're working in a planning stage of actually in a randomized controlled trial now, comparing 1 and 2 doses. And the reason we're not comparing 3 is that in some countries, and I'll go into this a little bit, there are actually 2 doses is the standard of care for younger girls and boys. And they're only doing 3 doses if you're over 15. And so this would be a 4-arm randomized controlled trial where we compare 1 and 2 doses of Cervarix with 1 and 2 doses of Gardasil. And it would be a non-inferiority trial so that we'd show that in immunogenicity and protection against 6-month infections that last 6 months, that there's no inferiority between 1 versus 2 doses of either vaccine. And we'll probably run it for 4 years. So we think that this is going to be an expensive trial, but it's going to be very important because in terms of implementation around the world, if we just have to give 1 dose, it's going to be amazing. But even in the United States, I did a back of the envelope calculation, and this trial might cost $60 million, okay, or maybe more. But if you calculate what we spend on Cervarix and Gardasil in the United States, if you go from 3 doses to 1 dose, you'll make up that money in less than 2 months, okay? Now, the NCI is not going to be getting that money. That's the problem. But in terms of healthcare expenses, it could be a huge savings. So that would be in 2 months, we would make up the money of the trial. So we really think it's worthwhile to really do this, because if we don't do a randomized trial, then no regulator is going to license 1 dose based upon this post hoc analysis we did in Costa Rica that I showed you some data from. So conclusion from HPV vaccine efficacy, it got screwed up a little bit on the Mac to PC conversion. So the VLTP vaccines are highly effective at protection against a spectrum of anogenital HPV endpoints, from incident infection to high-grade precancer. Gardasil also protects against genital warts in women, but the protection is type restricted, consistent with it being antibody mediated. The duration of protection is unknown, but strong protection at 10 years after antibody levels have plateaued, I think is really encouraging. We think it's well worth the efforts to now see whether 1 dose can give long-term protection and move the whole field into 1 dose. So now HPV, we turn into a little bit now into some implementation stuff in the last 10 minutes or so. So we've been, for a long time, been talking about HPV vaccines as the new kids on the block. And I think we really have to consider them now established products. They've been licensed worldwide. There's been over 100 million doses of Gardasil delivered, over 25 million of Cervarix. As I mentioned, Gardasil was approved for men in 2009 and for anal cancer in both sexes in 2010, whereas in women it was initially approved in 2006 and 2007. Now the countries in gray here have introduced vaccination programs. Some of them, for instance, in Latin America, just starting to get underway. But unfortunately, the countries shown in here have at best demonstration projects, oftentimes sponsored by Gavi. And the problem with this is that some of the areas that have the highest levels of cervical cancer, like India and Sub-Saharan Africa and Russia, don't have programs, okay? And so there's a lot of need for bringing programs into other countries. In many of these countries, the vaccines are licensed. In other words, you can buy them if you go to your pharmacy, but they're not part of the normal immunization program, so you have to spend your own $150 a dose to buy them. So and for that reason, they're not widely used. As I mentioned, some countries are going to 2 doses. At 0 and 6 months, this has been approved in the EU, in several other countries. And this was based on what are called immunobridging studies, where several studies have shown that 2 doses in young adults, say 9 to 14-year-olds, generates antibody titers that are non-inferior to giving 3 doses to 15 to 26-year-olds, in which the efficacy was established. So the obvious reasoning is, if you get as high antibody levels as these other people who are strongly protected, then you should be protected as well. This is actually seen with quite a few vaccines, that before you reach puberty, you actually respond better than after puberty. So by the time you reach puberty, your immune system's already going downhill. So in the last few minutes, we just talked about some outstanding implementation issues about who to vaccinate, how to deliver it to adolescents, what effect it'll have on cervical cancer screening programs, and importantly, delivery to economically disadvantaged individuals. So who to vaccinate? And there's a lot of talk about this. And the bottom line is, it's not one size fits all. It mostly depends upon what your resources are and what type of screening program you have in place. Ideally, you just kind of give it to everybody. But even in the United States, it's way too expensive to give it to everybody. You definitely want to vaccinate girls first, because cervical cancer dominates the HPV-associated cancers worldwide. So I wouldn't start vaccinating boys at all unless you make sure that all the girls have this strong protection. But what type of age you should continue vaccinating, where you should stop, is really very difficult to decide, because it's a law of diminishing returns. As a woman gets older, the chance that she isn't already infected or have already been exposed and is immune, and will get infected later because sexual activity new partners tend to go down with age, becomes greater. And so the chance of her being protected, there's some chance that she will derive benefit, but it tends to go down with age. In vaccinating males, actually, it makes more sense in countries that, one, have poor screening programs, okay? That have good screening programs, because now men have a greater proportion of the HPV-associated cancers. And in terms of herd immunity as well, if you're not covering women very well at low frequency, then vaccinating men may give you some benefit if you have some men that'll take it. So in the United States, vaccination of boys was first approved in 2011. So the CDC recommended routine vaccination for 11 and 12-year-old boys with catch-up up to 28. Previously to that, it was permissive, which just means if you want to do it, it's fine. But what that also means is that the government's not going to pay for it and HMOs aren't going to pay for it. So now we have it being recommended, and so that your health care should pay for it, and the government will pay for it if you can't afford it. And the reason they made this changing recommendation is there was such poor uptake by girls. I'll show you this in a minute. They figured, well, if we can vaccinate boys, we'll at least give them some secondary protection, even if it isn't as good as primary protection. And there was an indication that now that the vaccine prevented anal cancer, remember I said in 2011, the vaccine was licensed for prevention of anal cancer. And since this occurs in men and women, it's pretty hard to say a safe vaccine can't be given to somebody who has a chance of getting a cancer. So delivering 3 doses to young adults, it really is important that you vaccinate early, because this is some data from the UK and the United States, where remarkably, if you look at from the time of sexual debut, almost half of the women in both of these trials by 2 years had gotten an HPV infection. So you can't wait around too long to vaccinate. Unfortunately, uptake varies a lot in countries that have school-based vaccination, like UK and Australia. We're in the 70 to 80% range for 1 dose and 2 dose, which is pretty good. This is so little that the number became small. I don't know how that happened. But in the United States, 3-dose rates are 54%. I mean, 3-dose rates are only a third, and this is for girls, and 54% are 1-dose rate. Now, most people consider 1 dose a failure, but actually, as I just showed you, I'm starting to consider it more of a success than a failure. But still, the recommendation is in the United States is 3 doses. Okay, so if you ask me, should I give my daughter, or should I just get 1 dose, or should I get 3 doses? I can't tell you to get 1 dose. Okay, I can't tell you even to get 2 doses, even though that's what's happening to young people in Europe. And in France, in countries like France and Germany, it's even more abysmal than it is in the United States. But of note, here we have disorganized clinic-based vaccination, where you got to haul your child to a clinic 3 times in 6 months to get them vaccinated. And you can see that if you in comparison to other vaccines that are given to adolescents, that the vaccination rates of 3 and even 1 dose are behind these, and boys are just starting to come up. And so there's been a lot of, we think, provider hesitancy. So healthcare providers, when they talk about these vaccines, they say, you need to get this. And for the HPV vaccine, they say, well, it's available. If you want to take it, whatever. Because there's a big difference between the uptake of the other vaccines in adolescents. So I think a lot of it is on the pediatricians and GPs. But which is really unfortunate, because if you do distribute the vaccine and get 70 or 80% coverage, you can get really dramatic decreases in HPV disease. So this is a reduction in intermediate and high-grade dysplasias in Australia. And you can see that after vaccination in the younger girls, it just falls right off the table. It doesn't change in the older women who weren't being vaccinated. And the same is true for genital warts, where in the youngest age group, who were most being vaccinated, it fell by a remarkable 92%. In the next age group by 73, but in over 30 years old, it didn't change at all. Perhaps even more remarkable, during a time in which boys were not being vaccinated, the rate of genital warts in the youngest group, under 21 males, dropped by 82%. So this is an example where a sexually transmitted disease vaccine can really give you great herd immunity if you get good coverage rates. So what about cervical cancer screening programs? Well, this is something, we can't give up screening, unfortunately, because the vaccine won't help women with established lesions, and it's type restricted. So depending upon the vaccine you're getting, it won't prevent 10 to 30% of cervical cancers. And just to let you know, Pap screening is thought to be about 80% effective. So you'd be basically changing one effective program for another. So we need to convince vaccinated women to comply with recommendations for screening programs. And we really do need to do something about screening, though, because if you look at the total cost of preventing of HPV-associated cancers, or all the medical expenses associated with it, 80% is associated with cervical cancer screening, much more than any kind of treatment, okay? So if we want to save money in the healthcare, we really got to do something about cervical cancer screening. Well, what are we going to do? Well, it turns out that now we have this Pap screen for the most part, which is relatively inefficient because it has a low, what's called a negative predictive value. So if you get a Pap smear, there's still a reasonable chance that you have an abnormality that's been missed, and you'll go on to a high-grade lesion or cancer within 10 years. And so that's why we recommend that every 3 years you get screened, okay? Because it's not that efficient at picking up. Now, what we're moving towards is HPV DNA, which has a very high negative predictive value. If you don't have an HPV, genital tract HPV DNA, the chances of now getting cervical cancer in 10 years is almost zero, okay? So what we'll be able to do then is stretch out the length of time between screens. And so what we hope to do is combine vaccination at this early age to decrease this whole big bulge of HPV infection, and then screen a relatively few times in a woman's lifetime, maybe at 35, 45, and 55, and that this would then not only decrease the total number of cancers detected, but do it at a much more cost-effective way. So delivery to economic disadvantaged individuals, and as I pointed out earlier, this is where most cervical cancers occur. It's been estimated about 85%, so the vast majority. So how do we increase delivery to economically disadvantaged individuals. And this is going to be something we're going to have to attack in a multi-pronged fashion. Both companies, Merck and GSK, are committed to tier pricing. So if you're in Latin America, you get the vaccine at a lower price than you do in the United States. And I think that this is fair. And Gavi, the Global Alliance for Vaccine Implementation, is financing vaccine for the poorest countries, and the companies are giving it to Gavi for $5 a dose. And so this is slowly being introduced into some of the vaccination programs of the poorer countries. One solution, partial solution, will be vaccine manufacture in emerging countries. If you look at hepatitis B, it's a real good example. So when hepatitis B, the recombinant one, was first made, it was made in the West by major pharmaceutical companies. It cost about $100 a dose. Today, it's made in India and sold to UNICEF for 30 cents a dose. Now, it's taken 20 years to get from point A to point B, and we're hoping to short circuit that and get from point A to point B at a shorter period of time. And one of the companies that's farthest along in this is this company called Shiman Innovax, and they've actually figured out a way to make VLPs in E. coli, which is a very cheap way to make it, and they're in phase 3 trials. So it's likely that before too long, the women and perhaps the men in China will have access to a vaccine, which they don't have currently. And obviously, if we can administer 1 dose rather than 3 doses, this is going to be transformative in order to really deliver this vaccine to the people that need it. So in that, I'm going to quit and thank my collaborators, particularly Doug Lowy, who was my co-investigator in all of that I want to tell you. Thank you. I'm right on time. Yes. Just wait a second. What? There's like a fan right here.
You found out about the virus vaccination. How is it used for some related virus?
In terms of, does it do anything for them? I mean, does it?
Like the way you develop the vaccine.
Yeah, I have some slides. So, in terms of, can we use this as a pattern for other types of vaccines? Okay, I sometimes have a slide about that. So most of the other viruses that cause cancer, there's a problem with developing vaccines. Hepatitis B, we have one. Hepatitis C is very genetically unstable. It's HIV all over again. And it's been very difficult to develop a vaccine based upon antibodies for that. But fortunately, now we have this triple drug therapy for HCV, which looks like it's very effective. It's just whoppingly expensive right now. But again, we need emerging country manufacturers to make the drugs. And so that's going to be attacked by drugs. EBV is the one that has the best chance of having a commercial vaccine. And the reason is because it can be licensed for preventing infectious mononucleosis. It won't have to have a cancer endpoint for licensure. There's actually Jeff Cohen, who's in this building upstairs, who's developing what I think is going to be a great EBV vaccine. And it's based upon virus-like particles. He's getting 100 times more antibodies, neutralizing antibodies than have ever been seen with the EBV vaccine. So I really think that's going to be a really good vaccine. And then some other ones that are associated with cancers, for instance, HCLV causes adult T-cell leukemia. There's only a few thousand cases of that a year. It's unlikely that will be. The other one that causes a lot of cancers is Helicobacter pylori, a bacteria. And it's been difficult to develop vaccines of that because it burrows into the epithelium. And it's more likely that will be continued to be treated with antibiotics, which they're not great. The regimens are quite long, but they are effective. So again, there's the drug versus vaccine. Yes?
I'm convinced that the data of prophylactic vaccine is usefulness.
Mm-hmm.
What about therapeutic vaccines? For example, people who are adults, who have pre-existing antibodies, but they may have skin warts, which is also, with an HPV type. Is there any cross-reactive antibody that would prevent it from being used in therapeutic?
No, there's nothing really expressed on the surface of the cell that would be very susceptible to antibody. So if you want to do a therapeutic vaccine, you really depend upon T-cell mediated immunity. And people have been working on this quite a bit, and we're actually doing some work on it as well. And people have done trials against high-grade dysplasia, and they kind of work, but not too well. And nothing's been licensed. And my feeling, the biggest problem is that we've shown this in animal models, and actually Rena's working on this some, that if you vaccinate systemically, it makes a lot of systemic antibodies, but they actually don't reach the epithelium where the lesions are being maintained. These are interepithelial neoplasia we're trying to attack. And people have been fooled because what they do, like in an animal model or even people, they take out the whole tissue and they find T cells that are antigen specific. But if you look closely, histologically, they're either in the capillaries or in the dermis, in the stroma. They're not actually, they don't get to the epithelium. And women who get infections, oftentimes, if they have persistent infections, you'll see that they've mounted an immune response, a T cell response, because underneath the lesion in the dermis, you'll see this nest of T cells, but they can't seem to get into the epithelium. So the thing is to get away of generating large amounts of interepithelial neoplasia. And we think the best way to do that is to have the keratinocytes around the infected area express the antigen. So there's quite a bit of activity of that, and there's still plenty of lesions that will be around. And so both in academia and in companies, we're moving forward on that. But I think it's getting the location, getting the T cells where we need it. That's going to be the key. Anything else? Okay. Thank you.
Excellent. Okay, again, at 6 o'clock, we'll be going over to Building 10 to do the pathology tour. And our next speaker is Eva Szabo. She's chief of the Lung and Upper Aerodigestive Cancer Research Group at the NCI Division of Cancer Prevention. She got her degrees at Yale University and her MD from Duke University. She did an internal medicine residency at the New York University Medical Center. And then after completing a medical oncology fellowship at the NCI, she did a laboratory studying lung cancer biology. And now she's in the Division of Cancer Prevention and oversees the lung and head and neck cancer prevention trials. Her title, non-small cell lung cancer. Eva.
All right, so thank you, Terry. Is this working? Yeah, but I'm not hearing.
I can hear it.
Yeah? Okay, so people can hear? Okay. So thank you, Terry. So this is a big topic, non-small cell lung cancer. I'm going to give really a fairly brief overview of cancer treatment because it has really come a long way in the past, I'd say 10 years, more in the past 10 years than in the other 20 plus years that I've been paying attention. And then I'll talk about cancer prevention. Excuse me. The general concepts, examples of two specific types of agents that we've been using, budesonide, where we're going with aspirin, so non-steroidal category, and a drug called myo-inositol, and a little bit about the strategies we use for cancer prevention trials. And then again, a very brief overview of early detection because there's been major progress in that area as well. Okay, so a little bit about statistics. So, for this year, the estimate is 226,000 plus new cases, 158,000 plus deaths. I mean, this is the #1 cause of cancer mortality as well as incidence in the United States. It's a huge global problem. More cases than breast and prostate and colon, the next 3 most common cases together in terms of deaths. Although the good news is that cancer deaths are decreasing, but ever so slowly. Okay, let's see, there we go. So the peak in men happened, I don't know, 10 years ago or so, but you can see that it's still many more cases than all the other cancers. In women who had a lesser peak compared to other cancers, we're over the hump, but just starting to come down now. So you can't talk about lung cancer without talking about tobacco, because that is responsible for 85% of cases of lung cancer. And this is one of my favorite slides because it has so much information on it. So here's the cancer. Here's some emphysema, okay, some fibrosis. You see that there are these little black areas, so that's where the lung has been destroyed by smoking. That's a person with cancer. And here's the pack of cigarettes, okay, on the CT scan. So it is a horrible addiction, and that's been the cause of many, many deaths worldwide. So as I said, risk factors, 85%. Yes, we have a question. So it is, tobacco is a huge component of it. I wouldn't say that the physical hot products going in has no contribution, but it's tobacco. And tobacco and different delivery mechanisms still, for instance, when you chew tobacco and so on, it's still important. And it's the many, many carcinogens, many of which are activated once you light up the cigarette. So it's a complex question. But anyway, tobacco, passive smoking, prior aerodigestive malignancy, which is, of course, used in conjunction with tobacco exposure, and chronic obstructive pulmonary disease, emphysema, big risk factor, of course, not nearly as big as tobacco alone, and it's also caused by smoking. But there are other exposures, asbestos, radon, that's why we get our houses checked before they change hands during sales. Chromium, nickel, you name it, inorganic arsenic, much lesser in terms of contribution. It's tobacco. There are genetic predispositions. There's familial lung cancer, which is, has been associated with 6q23, the 25 abnormalities. The nicotinic acetylcholine receptor subunits, which are certain versions are associated with increased risk of lung cancer as well as increased risk of COPD. So that's a commonality. But bottom line is it's tobacco. So just a very quick review. We tend to think about lung cancer in two big categories, non-small cell and small cell. So non-small cell is everything which is pathologically not small cell. This is small cell, highly aggressive histology, about 20%, maybe less, of all lung cancers. And I really am not going to be talking a whole lot about this. This is the rest of lung cancer, non-small cell. The most common is adenocarcinoma. This includes both tobacco-related lung cancer, but also the lung cancer in never smokers tends to be adenocarcinoma. Squamous cell carcinoma is about 20%, used to be the most common form, but as cigarettes have changed and you get deeper penetration into the smaller airway, there's been a shift in the histologies, and there's more adenocarcinoma from tobacco exposure than squamous cell. Large cell, relatively uncommon, but not insignificant. And then other non-tobacco related pathologies, carcinoid, sarcomatoid, there are a number of relatively infrequent other pathologies. So the big picture, we still treat lung cancer on an anatomic basis. Early stage, stage 1, we take it out surgically. If it's a little bit more spread with involvement of lymph nodes, we'll do surgery as well as adjuvant chemotherapy, so systemic treatment. If it's even more spread to more distant but still regional lymph nodes, that's what we call stage 3A and B. We tend to do combined modality treatment. So we no longer just take it out, but we tend to do radiation and systemic chemotherapy together. And of course, if it's metastatic, if it's spread outside the lung or in multiple places in the lung, then you really need chemotherapy. And then we save radiation as needed for local control, for treatment of for treatment of areas that are creating problems. On rare occasion, we'll take out the isolated mets. that's all non-small cell. Small cell is a whole different beast. It is metastatic at presentation, even if you don't see where the metastases are. And so we give chemotherapy to everybody, plus or minus radiation for limited stage, so when it's all in the chest. And then we give prophylactic cranial radiation to prevent brain metastases, which are terribly common in this disease. I just put this in so you have a framework. This is not what we're talking about. So in terms of treatment, there are two main areas that have really revolutionized where we are today with lung cancer. One is targeted therapy, personalized precision medicine, okay? Lung cancer is actually the poster child in some respects for this. We now know that there are a number of specific abnormalities. This pie chart is for adenocarcinoma subtype. There are a number of specific abnormalities that can actually be targeted for treatment, and targeted therapies for a small number of these abnormalities make a big difference. What am I talking about? EGFR, epidermal growth factor receptor, okay? Its mutations in this particular molecule occur in about half of non-smokers with adenocarcinoma of the lung, okay? And treatment with specific tyrosine kinase inhibitors that target the mutant EGFR protein is highly effective, although not curative. So erlotinib, Tarceva, is the drug that is approved for first, second, and further lines treatment of non-small cell with EGFR mutant lung cancer, EGFR mutations. You get responses that with chemo maybe 3 to 5 months. With Tarceva in the proper population, 80% of the people will respond, and it's more like 10 to 14 months. And we now have second generation, third generation inhibitors that are about to go on the market, which target specific ways of specific resistance mutation. So we're really making a huge progress in this disease. However, we do not cure anybody, even with EGFR mutant lung cancer. We simply extend their lives. EML4-ALK, another abnormality that is now less common. It's about 5% of all non-small cell, still mainly in never smokers. I don't think I said that about EGFR, but it's true. And there are specific tyrosine kinase inhibitors, crizotinib, which gives about a 60% response rate, and the rest, or the majority of the rest of the people have stable disease. Again, about a 8 to 14 month duration of response. We now have second line agents, some of which are already approved. So we're making progress in extending the life of people with this kind of abnormality. It's a fusion protein that results, but we don't cure anybody. And there are multiple mechanisms of resistance, and so where you go for second, third line treatment is obviously a major area of research. Now we're starting to get into even less frequent abnormalities, the ROS1 rearrangement. Once again, this is now less than 2% of all cases of non-small cell. This is a abnormality that is once again responsive to crizotinib, again, mainly in never smokers, long duration of response, nobody gets cured. And then there are even less frequent multiple other abnormalities, HER2/neu, BRAF, RET, some of which you can target with specific drugs. But you can see that what we're doing is we're chipping away at small subgroups of the total pool of non-small cell with very significant therapies. But you can imagine that to do all the molecular analyses that you need to do to identify these not so common subgroups is making treatment of lung cancer very complex, very expensive. the path forward is a little bit difficult. So realistically, right now, these kinds of this precision medicine in the setting of lung cancer really applies to less than 20% of all comers, which leaves everybody else without those kinds of options. For squamous cell carcinoma, we're quite behind. There are certain abnormalities that are being looked at. FGF, the fibroblast growth factor receptor 1 amplifications are common. I don't have it on this slide in text. The PI3 kinase mutations are less common. This DDR2 is another abnormality, but none of these have gone forward to actual treatment, approved treatment modalities. This is all in terms of research right now. What is new and is making so that's one area of research. What's also new and making a huge splash, and you probably hear this every time there's a major meeting, are the immunotherapy approaches, which I'm, again, not going to do justice to by any stretch. But the checkpoint inhibitors, the programmed death receptor blockade, PD-1, PD-L1 blockade, there are now actually antibodies that target this checkpoint receptor, therefore upregulating T-cell activation. And there are very important and approved drugs. And I'm just showing you this one curve here, which shows second-line treatment, in this case, squamous lung cancer. This is the previously approved therapy. This is overall survival with docetaxel, second-line chemo treatment, versus nivolumab, which is a anti-PD-1 antibody that is now approved for second-line treatment of non-small cell. There's another one, pembrolizumab, that's also approved. And you see that you have significant improvement of survival. It applies to a minority of cases, but what you're seeing here is that for a long time out, these curves separate, and you have these long-term survivors. Again, a minority of all people with lung cancer, but we've just not seen that before. So for the first time, you're seeing these extended responses, sometimes complete, often what looks like partial, but probably with no viable tumor. And these people are living, some of them are living 2, 3, 4 years with metastatic non-small cell lung cancer, which was unheard of 5 years ago, okay? And still doesn't occur, except in rare occasions with the targeted therapies. So this is really a new area. We don't know how to use these drugs very well yet. We give them to a lot of people, but only about 20% of people respond. So there's a lot of work being done, and I suspect that when I give this lecture in 5 years, it'll be given in quite a different manner, and that's very exciting. That's not what I do in my day job, and so that's not what Terry asked me to talk about. So I'm going to now talk about how else can you improve morbidity and mortality from lung cancer. Okay, talked about the therapeutics, but it's really how can you prevent lung cancer, or how can you detect it early so that it doesn't become metastatic? And I think this segues very nicely from John Schiller's presentation about HPV. I wish we had the absolute causal infective agent for all of lung cancer, but it's not that simple. Not that it's simple even in the cervix, but it's not that simple in lung cancer. So as John showed, the progression of preneoplasia in the cervix, they're very similar processes operational in the lung. And so that lengthy period of time between your genetic hit from tobacco, let's say, and the time that you actually get cancer really affords an opportunity to prevent progression or for early detection. And that's what I'm going to be talking about. So I told you that tobacco is the major offending agent. Obviously, if nobody smoked, there'd be a heck of a lot less lung cancer. What about if people quit? Should you quit? Well, this is an interesting study. It was actually a emphysema study. But what you see here is that people who were followed for an average of 15 years, if they stopped smoking, okay, then the death from lung cancer was about halved. This is people who stopped smoking, it's people who continue to smoke. These are the people who intermittently stopped. So this tells you that after 15 years of quitting, you can very substantially decrease your risk of lung cancer. What you don't see on this slide is that after 5 years of quitting, there was no difference in lung cancer deaths. So this is a long-term process, okay? And it's because with tobacco exposure, you continue to ramp up, or you continue to get more and more abnormalities, and you continue to increase your risk, and you don't actually undo that damage easily. But if you don't continue to increase the damage, then you plateau off. And that's what you're seeing here. And that's why you're seeing it at 15 years of smoking, not at smoking cessation, not at 5 years. And this is very different from heart disease, where if you stop smoking, your risk of heart disease goes down pretty quickly within a year or two. Okay? Doesn't mean you shouldn't stop smoking. It's critical that you stop smoking whenever. However, the benefits in terms of lung cancer don't become obvious until years down the line. So, and obviously a lot of people are working on ways to prevent or to help people stop smoking. It is not an easy thing to do, and we need to make more progress there. It's not my area of expertise. What I'm going to talk to you about now is really cancer chemoprevention, which is the use of various strategies to suppress or reverse the process, that lengthy process that starts with an abnormal cell going through different levels of preneoplasia, dysplasia, as we talked about in cervix, and ending up with an invasive cancer, okay? And so this is a long process. The goals are to regress those early preneoplastic lesions, okay, to prevent the development of new foci of neoplastic, preneoplastic, and cancer lesions, and to suppress the recurrence once somebody has been treated successfully, let's say, with surgery for an early stage cancer. And as you can imagine, there are a lot of different biological processes all wrapped up in this one concept. So the rationale for going towards this kind of an approach is because, as I told you, metastatic cancer is still very rarely curable, okay? And the survival from lung cancer, as of right now, has not changed so substantially over the past 30 to 40 years, okay? It's still about 16% 5-year survival. But we know from other organ systems, such as breast cancer, that if you treat with effective therapies, and for breast cancer it's tamoxifen or raloxifene, you can prevent new cancers from occurring. We know that from preclinical modeling. And then the last piece of rationale for going a preventive approach is that it's a long process to get from the initial damage to the actual invasive cancer. So if we knew how to treat curatively when a cancer is metastatic, or at least very limited metastatic, that's the time to treat, right? Because you know who's the person who needs to be treated. However, right now, we don't know. We don't have good therapies. And even with the excitement of immunotherapy, it still is applicable to only a subset of all patients with lung cancer. So we do think that early cancer is much more curable than late. For instance, if you take it out at stage 1, you have much better survival than stage 4, where you have 0% long-term survival as of today. We therefore think that the less molecularly complex precursor lesions should be more curable than even the early invasive cancer. That's a hypothesis. That's not a known fact. Could we prevent carcinogen-induced damage? in a way that is analogous to preventing HPV infection, where HPV is the absolute causal organism or the absolute cause for cervical cancer. But working against this is the fact that there are multiple pathways for lung carcinogenesis with different offending agents, with different molecular signaling pathways involved. So that's one consideration. We think early needs to be proven. Toxicity of the intervention is another major consideration. We give chemotherapy, immunotherapy. It's acceptable short-term in the setting of advanced cancer, absolutely not acceptable in the setting of precancer or in high-risk setting. So you really need to go to strategies that are acceptable, that are tolerable in people who are otherwise healthy and who don't know that they are going to get cancer 5 or 10 years from now. The target population is very important. All smokers, 90 million in the United States. What did I say about how many lung cancers? You know, it's 220,000, and add a few, 20, 40,000 people who are living with metastatic cancer. The vast majority of smokers aren't going to get lung cancer, and they're not going to get it today. They may get it, it's about 1 in 8, and it's, of course, a dose response. So many are at risk, but relatively few get cancer at any given year, and we can't figure out who are the ones who are going to get it. And when it comes to the 15% of lung cancer that is in non-smokers, we have no idea who are the non-smokers. So we're not even studying non-smokers at risk for cancer. Finally, cost and resources. You can give lots of preventive therapies, but the more people you target compared to the ones who actually get the disease, the more you spread out your resources, the more you make people who are not patients into patients. There's a psychological impact. So there are lots of considerations when you should deliver interventions. So the genetic linkage is very hard to study because the vast majority is together with smoking exposure. You know, there's a small number of families with certain kind of mutations, the T790M EGFR mutation, and there are some other abnormalities that have been identified that these families are at very high risk for lung cancer and develop multiple cancers. But that's a teeny, teeny, tiny fraction of all. So yes, one would want to study these, but this is a different pathogenesis from the typical smoking associate. So, you know, when we're studying lung cancer prevention, we focus on heavy smokers, typically 30-pack years. But even those people, you know, most of them don't develop cancer in the 2, 3, 4 years that we study them. So it's a challenge. So, but having said that, we don't give up. How do we develop preventive strategies? We need to look at the risk and the benefit. The benefit in preventing cancer, associated morbidity, mortality, but the risk of any given intervention, lack of the adverse side effects that can increase morbidity and mortality from other diseases, as well as the tolerability. So some of you may be aware of the drug Vioxx, a COX-2 inhibitor. It's similar to celecoxib, which is still on the market. Well, Vioxx, rofecoxib, very effective drug for pain, was actually in a colon polyp prevention, the colon cancer prevention trial, where it was given and studied over several years. It had been approved after fairly short-term studies, less than a year in duration, again, very effective. But when given long-term, there was about up to a 3-fold increase in cardiovascular disease. The drug came right off the market, okay? So when one is trying to prevent one disease, you have to make sure that you don't cause another, okay? Okay, so how do we move forward? How do we identify agents? mechanism. If you know the mechanism, you're golden, okay? HPV vaccine and cervical cancer. That's not to say that that was not a huge amount of study, of research and terrific conceptual insights. But once the insight was made, the path was forward as the path was clear as to how to move forward. For lung cancer, many different molecular pathways of molecular pathogenesis. Not so easy how to predict who's going to get what kind of lung cancer and when. So it's a challenge. So we go to preclinical models, and we use those, for instance, carcinogen-treated models, transgenic animals, and I'll show you a couple of examples. We go to observational epidemiology, looking at people who've been treated with various drugs, whether you can decrease the incidence of a specific cancer. Lung cancer, of course, is what we're talking about here. And in clinical trials, for instance, adjuvant clinical trials, to see whether we can prevent the incidence of second primary cancers. So those are sort of the main ways of identifying agents. And then, of course, you take them into clinical trials. So I'm going to give you a couple of stories to show you how we've moved forward in this area. And one of them is the inflammation story, which has been around for quite a while, really going back 40 or so years in animal studies showing that corticosteroids, which dampen inflammation, can prevent cancer. Cancer of the skin, cancer in the lung, and especially delivery through the inhalational route, all in animal models. Epidemiology is a little bit more mixed for lung cancer. Mainly, so you generally used steroids for asthma. Those people are not such high risk for lung cancer, or emphysema. Those people are at higher risk. But most of the studies have been somewhat short. There is at least one study in the literature showing that people with emphysema who use inhaled steroids versus other classes of drugs have a substantially decreased incidence of lung cancer. Not the strongest evidence, but it's what we got. A number of animal studies were performed, actually at the Division of Cancer Prevention under contract. This is one example using the drug budesonide, which is an inhaled steroid, actually oral and inhaled. In this case, it was given in the diet. And what you see here is that with increasing doses of budesonide in the diet, you really decrease the number of tumors after giving a carcinogen to animals by about 80%. And not only that, this is a model where the animals develop first adenomas and then adenocarcinomas. And what you do is you shift back to an adenoma histology. So these 20% of tumors that are there are much more likely to be adenomas than carcinomas if the animals were treated with budesonide. So based on these studies, the question becomes, how do you move to a human being? And the way we chose to move forward is by focusing on premalignancies in the lung, in this case, bronchial dysplasia, which is premalignancy leading to squamous cell carcinoma. And so with increasing grades of abnormality, this is the sequence that leads to invasive squamous cell carcinoma, okay? The natural history of these lesions is that actually a fair number of them develop cancer. This is a pretty recent study where people who had bronchial dysplasia were followed over time, and about a third of them developed invasive cancer between 1 and 2 years after the diagnosis of the bronchial dysplasia. But it's not just the precursor, it's also a risk marker for the entire abnormal field, which has been damaged by tobacco exposure, because about 40% of the cancers developed from that area of dysplasia, but the 60% of the cancers developed elsewhere, either from the bronchial tree somewhere else, or else even as adenocarcinomas in the periphery. So bronchial dysplasia is a precursor to some cancers, but it's very much a risk marker of a whole abnormal field. So the study that we performed with our collaborator, Stephen Lamb, in British Columbia Cancer Agency, took 112 smokers with dysplasia. They underwent bronchoscopy, so that's how we knew that they had bronchial dysplasia, and also CT screening to look at their peripheral lung. And then they were treated for 6 months with inhaled budesonide or placebo based on those animal data. And then underwent a second bronchoscopy to look for the number of sites and the grades of dysplasia. And to show you the complexity of these studies, to get the 112 on study, Dr. Lamb actually screened over 1,000 people with sputum to identify those who have some level of abnormality. He then did bronchoscopy, and that was about half of them. He then did bronchoscopy on about 350 people. So out of the 540 who had abnormalities, 350 or so agreed to have a bronchoscopy, and about a third of them eventually wound up going on study. So these are technically very labor intensive. Unfortunately, this study was negative. We can talk about why. The animal model was actually looking at adenocarcinoma, and we were looking at squamous carcinogenesis, looking at bronchial dysplasia. But what we did find was that people also tended to have CT lung nodules, small nodules. This was in the early days of CT screening, before it became an approved modality. And there was a very significant decrease in the number of persistent CT nodules in those who had inhaled budesonide versus placebo. So this led rise to a study that looked at the peripheral lung, CT screened nodules, such as this little ditzel right here. Our colleagues at the European Institute of Oncology in Italy had a CT screening trial. And so we took 202 participants who had persistent small nodules, were not felt to be cancer, because if they had cancer, they obviously went for treatment. If it was questionable, they went for more diagnostic studies. So these were smaller nodules. They had to be persistent, and then they were randomized for a year of inhaled budesonide versus placebo, okay, and then had their next screening CT. And what we're looking for was shrinkage of lung nodules. Now, this is really the first study that looked at the peripheral lung. And honestly, we didn't know what we should be looking for. So we took all lung nodules that were persistent. And what we found is that the majority of the lung nodules, 70%, were solid. And over the course of a year, if they were there prior to the onset of the study, they didn't change at all. But the non-solid nodules, which I'm going to describe in a second, did appear to get smaller. And actually over time, so the 1 year of intervention and then 5 years of follow-up, over time they continued to get smaller, whereas the placebo arm, they did not get significantly smaller. So this suggested to us that maybe we should be looking only at the non-solid or partially solid nodules, because the solid ones are fibrosis, they're nothing. Why is that? So one of the precursors for adenocarcinoma, so this is a non-solid nodule on CT scan, is this lesion here, a typical adenomatous hyperplasia. It's a well-described premalignancy for the peripheral lung. And until CT screening, the natural history was really not well understood at all, because you take it out sometimes because there was something in the chest, or it happened to be there when you resected for an adjacent lung cancer. But we now know that these non-solid nodules, somewhere between 25 and 50% of them are actually atypical adenomatous hyperplasia. Doesn't mean that they all progress to cancer, but they are premalignancy. And perhaps this is the population that we need to be looking at. Here's one study that showed that these ground glass opacities, okay, will grow over time. And if it's in smokers, which is, of course, our chemoprevention study populations, they have a much higher incidence of progressing than if they occur in non-smokers. And so I'll show you just, this is a little, actually a family friend of ours who really shows you what happens with these non-solid nodules and how variable they are. So 11 years ago, she had some chest pain. She went to the emergency room. They thought she might have a pulmonary embolus, which she didn't, but what they saw were actually several little nodules, this ground glass opacity. And of course, they told her, you need to have it followed up. This could be a lung cancer. So 3 months later, there it is again. It's there, different quality CT, maybe a little bit less obvious, but not much changed. So like all good people, she went on her merry way and didn't come back a year later. Until 2010, 5 years ago, where she had chest pain again, wound up in the ER. And then here's that nodule yet again. Didn't have a pulmonary embolus, but this nodule now is bigger. It's substantially bigger, still ground glass. So same consistency. So this time she listened and went back a year later for more follow-up. So this is what you compare with this initial thing. And now there's this solid center. Okay, there's still some adjacent, hard to see, ground glass opacities. And when this was taken out, it was an invasive adenocarcinoma with adjacent areas of atypical adenomatous hyperplasia. So pre-malignancy that has taken how many years? Really 7 years before it was diagnosed as an invasive cancer. So there's a lot of variability over how long this takes, and follow-up is needed. We looked with my colleague Paul Pinsky to see whether these non-calcified ground glass opacities are associated with cancer in the National Lung Screening Trial, the CT screening study. And what you see here is that people underwent 3 rounds of screening, so 0, 12, and 24 months, but their risk of lung cancer, if they had a ground glass opacity, really only started to go up at 5 years or so, suggesting that these ground glass opacities, some of them are actually cancer precursors, just like the case that I showed you in the previous slide. Now, so how are we moving forward? So from our budesonide study, we came to the conclusion that these ground glass opacities are what we need to look at. What drugs should we be looking at? Okay, a lot of preclinical data, but not so much clinical. So aspirin has a new life now in cancer prevention. This is a patient-level meta-analysis of multiple studies of aspirin versus placebo. In this case, all the studies were actually done for cardiovascular or stroke prevention. But if you look at risk of cancer death, okay, it starts to take off 5 years. Aspirin is substantially lower than the control placebo. And at 5 years, you start to have a significant decrease in lung cancer death, about a 20 to 30% effect over time. So this suggests to me that within 5 years, you go from having a premalignant lesion all the way to death and lung cancer. Okay, most people, if you have an invasive cancer, you die within 2 to 5 years. Okay, so this suggests that we should be looking at aspirin in the setting of premalignancy, and we're doing this again with our colleagues in Europe who have CT screening, and we're looking at asymptomatic current and former smokers and giving them with persistent non-solid or part solid nodules and giving them a year of aspirin or placebo and then we'll be looking by CT scans specifically at those non-solid nodules. And we're about a third of the way done right now. We're also asking whether aspirin can modulate the abnormal field and whether you really need to give it every day compared to intermittently. So there's accruing data that you don't actually have to give chemopreventive interventions every single day, that you can do a week on, week off, 3 weeks on, 3 weeks off, different regimens. Why would we want to do this? Because the less drug you take, the less side effects you have. So if you can be off for a week or off for 3 weeks, you can regenerate your stomach mucosa and you don't get as much bleeding, which is of course the problem you get with aspirin. So we're doing this study, which is looking at a readout of abnormal gene expression. It's actually quite a long story, but we're looking at nasal swabs, okay? Looking at gene expression, smoking-related signature in the nose with the aspirin given for a week on versus week off, or comparing that with aspirin and a lipoxygenase inhibitor, xyluten, versus placebo. And so in a few years, I'll have data on this. Okay, quick story, because we've gotten quite far in this and it shows us a way forward. Myoinositol, glucose isomer, it's actually a dietary compound, has been studied minimally in diabetes, in polycystic ovaries, but it's actually very appealing because it is generally regarded as safe, GRAS, using FDA terminology. And there are a number of animal studies showing that it can inhibit carcinogen-induced tumors in mice, both with carcinogen, with mainstream and side stream smoke. And so this is a agent that we got interested in because of the work of Lee Wattenberg, who was one of the giants of cancer chemoprevention, who passed away last year in his 90s. And so we performed a phase 1 clinical trial, again with Stephen Lamb, based on these animal data, showing that we can tolerably deliver quite a large amount, 18 grams per day. And in this completely uncontrolled dose-finding safety study, we saw that there was a very considerable regression of bronchial dysplasia compared to historical controls. Okay, so this is the worst kind of study, but preliminary evidence that maybe we should look further. What was interesting about the study is that Dr. Lamb did bronchial brushings from the normal bronchial tree, okay? And Avi Spira at Boston University did gene expression analysis from people who have bronchial dysplasia, who were treated with myoinositol or placebo, but also from a lot of other people who either had adjacent lung cancers, who were smokers, who had with and without dysplasia. And what he was able to show was that there is increased activation of the PI3 kinase pathway in the normal epithelium of smokers who had dysplasia, but not healthy smokers who did not have documented dysplasia. And myoinositol inhibited this activation, again, in the normal bronchial airways, okay, in people who had adjacent dysplasia. So this really gives us a way to move forward, doing this kind of molecular analysis to answer many, many questions. First question is, are those the highest risk people, those who have PI3 kinase activation? Are those the people who we really ought to be targeting because there's this association with the pre-malignancy bronchial dysplasia? It allows us to go in and do the brushings without necessarily having to do multiple biopsies, a little bit easier than having to do multiple biopsies. But more importantly, it allows us to potentially identify the right cohort. And it gives us a new clinical trial model, one where we would be looking at shorter interventions in smaller numbers of participants, looking at the high throughput kind of analysis, such as done with this gene expression PI3 kinase signature. So this is a potential way to move forward, which we're really exploring right now. And so the follow-up to this small phase 1 study is this phase 2b, placebo-controlled blinded study giving myoinositol versus placebo for 6 months. 85 people were randomized, and we're really doing the analysis even as we speak. So this is how we move forward, I think. Okay, I'm going to do 5 minutes on early detection because unlike chemoprevention where we have no approved therapies, for early detection, we have made huge strides. Lest anything be too easy, okay? Issues in screening, okay? And I don't know whether you guys get a lecture or not, but sort of the 3 big biases which make life difficult, okay? Lead time bias. You can, if you screen, you can identify earlier disease, but it doesn't mean that the people will live any longer. Survival will appear longer, but people still die at their pre-appointed time. Okay, that's called lead time bias because you're identifying the disease earlier, but you're not actually postponing death. So you just think you're making progress. Length bias. There's lots of disease out there. Screening tends to diagnose the more indolent disease with a longer preclinical phase. So these are the better prognosis cancers. So you have a better outcome, but those highly virulent cancers that people die from quickly, you don't find those by screening. So an example, small cell lung cancer, very aggressive, moves quickly. You don't find that with CT screening. Finally, overdiagnosis. Lots of things that look abnormal, but that aren't necessarily clinically important. This was well documented with autopsy studies looking at prostate cancer. You know, most men, by the time that they're in their 60s, 70s, and probably by the time they're 80, almost everybody has prostate cancer. But in fact, very few people, not very few, but few people, relatively few people die from prostate cancer because most of it is clinically unimportant. And so overdiagnosis is a major problem. We used to think that there's no such thing as overdiagnosis in lung cancer, but that's actually not quite true. So those are the potential biases. And then you have to remember that if you're going to screen, there's going to be morbidity from the procedures, the follow-up, right, of abnormal things. There's going to be some mortality because it's going to be taken from the very carefully controlled centers that do the trials to the general community. And there's always there's always a cost, a monetary cost. So just 2 studies that I want to talk about. PLCO, which looked at the prostate, lung, colorectal, and ovarian cancer early detection trial. This is the chest X-ray versus nothing, usual care for 4 screens, looking for lung cancer, decreased deaths, and of course, nothing. So chest X-ray is not useful for screening for lung cancer. This is actually sort of the definitive study. There had been many others previously. But the National Lung Screening Trial is quite different. This was a CT screening trial, 53,000 smokers, current and former, 30-pack years, had to quit within a certain amount of time, and they had 3 helical CT screens versus chest X-ray. And the results were very positive, 20% reduction of lung cancer death, okay? So this isn't lung cancer incidence, it's actually death. Overall, there was a 6.7% reduction in all-cause mortality because lung cancer is a significant cause of all part of mortality. But 24% of the CTs were, quote, positive, okay, as opposed to 6.9% of chest x-rays. So there were a lot of positives that didn't turn out to be lung cancer, okay? These are just the Kaplan-Meier curves showing the decrease in, so up here is the cumulative number of lung cancers. So you see that they continue to go up, but low-dose CT has more lung cancers than chest x-ray, and that's reflected in the decreased number of deaths. This is low-dose CT, this is chest x-ray. Remember, screening was here, but the deaths come later. Okay, so how do we move forward? A lot of work being done to figure out which of these nodules are the important nodules, the ones that are associated with cancer as opposed to all the other things that happen in your lung, and trying to move this to identify those people who are going to be at highest risk, whom we could then target for prevention. And so this is just one example of a risk model. It's called the Brock model, Brock University in Canada, where they looked at the risk of lung cancer in nodules just from one single CT. And if you put into this model the age, sex, family history, emphysema, and various parameters related to the nodule, the type of nodule, ground glass versus other, et cetera, you can actually identify the highest risk smokers who are most likely to develop lung cancer within the next 3 to 4 years. And that's the population that we hope to target for cancer prevention trials. So this is, again, a work in progress, but it brings together the early detection and the prevention components. So I'm done. Lots of progress. This lecture is, for many years, I was simply reusing the same lecture year after year. And it's delightful to be able to have to change it. So tremendous progress has been made. Precision medicine is on the map for lung cancer. It's applicable to significant, but still small subsets of advanced stage cancers, cancer patients. There's increased survival, but no cures. These are the early days of immunotherapy, and I'm sure you'll have good lectures about that. Prolonged survival, but in a small subset of patients. Early detection is also making a mark, decreased lung cancer mortality. We're still figuring out how to roll it out in the best cost-effective manner, but it is an approved, I say that in quote, but it's approved by the U.S. Preventive Services Task Force, and Medicare pays for it. And as we're making all this progress, we are identifying new targets and tools which we can then move to chemoprevention so that we can prevent those cancers in the first place. And I think that's it. So I'm happy to answer any questions. Yes, ma'am.
Any studies planned in conjunction with maybe with CMS as they're rolling out this new coverage to look at, before and after, or even though it would be an observational study?
Right. So there's going to be a registry associated with these CT rollouts, and so in terms of identifying populations and so on, yes, there'll be a lot of work done. But in terms of interventions, not really. There's not an easy way to interface with that. However, as more CT screening is occurring, we're going to have all these people who are going to be followed. And so we're working with various big centers to try and capture that population. It's a little early. That's why we went to Italy, because they had the CT screening. But it's a little early for any given center to have enough years of follow-up for us to be able to put trials in there. But that's our hope, because we're going to be seeing lots of these people with persistent nodules and a lot of work going on there.
I have one other question, which is about the anti-inflammatory properties of some statins.
Mm-hmm.
And I wondered if there's been any work on it. I haven't even seen any epidemiologic studies that looked at cancer incidence, although there may well be.
There are. I don't think we've seen a signal particularly for lung, but yes, people have, there have been colon, prostate, but some studies show, some studies don't show. So it's the epi signal has been not the most consistent. Having said that, there's some animal data that also, particularly for colon, Levy's work, that suggests that there may be some benefit. It's been a little bit difficult to study because so many people in the United States are on statins. So there was an attempt to do a colon polyp prevention trial, a phase 3 study by the cooperative groups. And I think that study has closed because they just couldn't accrue. So, so you can make the argument, well, anti-inflammatory, why not go to statins? My argument would be, well, go for something that's truly anti-inflammatory first. If you want to look at statins for their HMG-CoA reductase activity or downstream signals, then study statins, but not for, I like to study the most effective agent for the putative mechanism that I'm trying to study. That's my approach. All right. Thank you for staying to the end.
And I have a comment. I opened my Time magazine on Friday, and on the third page, there was an advertisement by Merck for nivolumab, the immune checkpoint inhibitor for non-small cell lung cancer.